Hello, everybody. Good afternoon. We're going to get started with grand rounds today. You see our CME MOC request form up there. I just got mine saying that I got credit for, so those things actually work. So please feel free to get your CME and MOC. Today, we have a pleasure of having one of our chief residents, again, presenting grand rounds. As many of you know, these are often the highlight of our grand round series. From the schedule, you probably saw that Dr. Bianchina is supposed to be presenting with Dr. Ali Fuher, but unfortunately, Ali is not going to be here today. But we do want to recognize Dr. Fuher for her contributions to this talk. So I am going to give an introduction to Ali. Dr. Fuher has played a significant role in creating the content of this talk, and I also appreciate Nick insisting on going forward with this talk, even though she can't be here. Dr. Fuher earned her bachelor's and MD degree from the University of Minnesota. And she came here for residency, then obviously stayed on as a CMR. She's been recognized with several prestigious honors, including the Alpha Epsilon Lambda Foundation Award, as well as a Star Research Achievement Award. She has been very active as an author. She's published 8 papers and 17 abstracts during her residency. Today's speaker, Dr. Bianchina. Nick received his bachelor's degree from Drake University before coming to CU. He completed his MD in internal medicine residency program or training here and then stayed on as a chief resident. He was nominated for the Longitudinal Clerkship Teacher of the Year Award and also received the Elena Kazarian Intern of the Year Award as an intern. He's furthered his education in leadership space through the hospitalist training track and also the medical educator pathway. He's been an active teacher, curriculum developer, and as well as serving on multiple communities or committees in the school and the residency. We are very fortunate to have retained both Ali and Nick for next year. Ali will be here as a critical care fellow, and Nick will be part of the hospitalist group here at University of Colorado Hospitals. Nick, again, we want to thank you on insisting on pushing forward in this talk. We know this is a added pressure on you, and we welcome you to the stage.
Awesome. Can you hear me okay? Perfect. Thank you all so much for being here and taking time out of your busy clinical service, and thank you so much for that kind introduction. Today, I'll be talking about the white coat, why some wear them, why some don't, and why it matters. I want to echo the sentiments from Dr. Stenium and really thank Dr. Fuher, who's been such an incredible source of support this entire year, who developed a lot of the content for this talk, was the original inspiration for this talk. And I'm so sad she can't be here today, but very happy she'll be here as a critical care fellow next year. So what are we going to talk about today? We will take you through 3 major points of the white coat. First, we're going to talk about the history of the white coat leading up to its practice today. We will then talk about the current trends and the use of the white coat, both nationally and locally here at the University of Colorado. And then ultimately spend a majority of our time talking about the pros and cons of wearing the white coat for you to think about in your own clinical practice. And ultimately, my goal is to hopefully share with you all that the white coat may be an underutilized tool in your current clinical practice. I have no financial disclosures. And then I do just want to make one disclaimer before we begin the talk today, which is that I am a straight white male giving a talk about the white coat, which has held a lot of privilege in academic medicine. And I recognize that some of the things that I'm talking about today are more likely to be experienced by our female physician colleagues and those from minoritized backgrounds. And I recognize that, and hopefully we can have a dialogue about that as the talk moves forward. Also, a lot of the literature that we're going to be talking about today operates without a lot of conversations on racial identity in the white coat, operates in a very gender binary descriptions of the white coat. And so knowing that we need further literature to address some of the evolving landscape currently today. So let us begin where the white coat entered my life. This is a photo of me in 2017 when I was given my white coat at my white coat ceremony here at CU. I have no doctors in my family, and I was so excited to put on that white coat. I had worked so hard to get to that spot. I put it on and I felt, I have made it. This is exactly what I was hoping to do, but I felt this burden. It was a heavy coat because now I was entrusted with patient care. Now I was feeling that I had this ownership to live up to the physicians that had come before me. But like many medical students and residents, I hung up the white coat, put it in my closet, and then I did not touch it again until I became a first-time attending, where I thought, should I be wearing this white coat? I'd seen a lot of attendings do it before, and so I wondered, what is the white coat saying for me? I really worried specifically about how the white coat made my team feel. Did it make them feel that I was on some higher hierarchy than them? I didn't want to destroy the psychological safety, but I also had other personal reasons for wearing the white coat that we'll talk about. So ultimately, as you can see from this photo, I did choose to wear the white coat. But the other place that the white coat entered my conversation in Allie's was specifically around our role in education in the white coat. See, Allie had a resident come to her in the fall, who's a woman of color, and said, I've been experiencing a lot of misidentification. Nobody here thinks that I'm a doctor. I'm getting constant amount of questions that I feel like my male counterparts aren't getting. Should I wear the white coat? Do you think the white coat would help decrease this? But then on the flip side, no one here really wears the white coat in our residency. So if I wear it, am I saying something? Am I going to be made fun of? And that truly was the impetus for our conversation here today. So just a poll of the room, raise your hands for who here wears a white coat daily in clinical practice. Okay. Who here does not? A lot more in this room do not. Anyone that it depends on where you're practicing, outpatient, inpatient? For that? Okay, great. All right, so let's kick off and talk about the history of the white coat. We'll start our conversation in 1875. This here is a picture of physicians done by Thomas Eakins. And in particular, at this time, physicians were seen wearing a suit, this very formal attire, a black color. And often this was seen as the predominant role for the physician as this profession, similar to the attire that clergymen and lawyers would wear as well. Some historians also even theorize that the black nature of the attire at this time was very intentional, that medicine did not have the same advances it does today, and the white coat almost symbolized the grim reaper, the seriousness nature of the profession, and the kind of doom and gloom that it had. It's unclear exactly why the white coat transitioned and became the predominant clinical practice, but you can see in 1889, just a few years later, the predominant attire, again in a painting done by the same painter, is this white lab coat. Probably prompted by a lot of concerns for cleanliness, protection of the underlying clothing, but also the white adds a little bit more levity to the profession, a little bit more angelic nature to the profession. And this really became the predominant attire associated with physicians. And to the point that it's been so associated with physicians that it's hard to see the white coat as symbolizing anything else. In 1946, you can see the physician here wearing a white coat and endorsing a certain brand of cigarettes. 1972, the popular TV show MASH, all the physicians in that show wore a white coat. In the Best Medical Show, ER, in 1994, you can see physicians wearing a white coat here with business casual underneath. But interestingly, you also notice some physicians in this photo are not wearing a white coat. And we started to maybe have a little bit of a transition away towards the white coat. In 1993 is actually when we get the first ever white coat ceremony, which surprised me. It's like more recent than I would have thought. This was led by Dr. Arnold P. Gold, who's a pediatric neurologist, the founder of the Gold Humanism Society, who really wanted the white coat to speak for the symbolism of the profession that I felt. So you now have this weight of the things you're carrying for the patient and bringing back the humanity for why we do what we do in terms of patient care. However, we've now started seeing a transition away from the white coat in the 2000s. So I'm curious here from the room, if you all could maybe theorize, why do you think that people nowadays don't wear a white coat? Cleanliness, hard to keep clean. Nobody else does. We saw that with just the hand raise. The infection, it's a barrier to connecting with patients. It's unnecessary. It's more comfortable. It's not part of the culture. It might be unapproachable. So there's a lot of reasons why people are choosing not to wear the white coat. And this kind of speaks to a lot of the reasons that people transitioned away from the white coat starting in kind of the 2000s. And that was largely seen with concerns for infection risk, that it promoted a sense of hierarchy and elitism, both from the standpoint of patients being concerned that they didn't want the physician to feel better than them, but also within the healthcare system, And then ultimately COVID-19, when we all took off our white coats, put on scrubs to care for patients, and just never put those white coats on again. In fact, a few policies have been implemented to help regulate the use of the white coat. For example, the NHS in England implemented a white coat ban in 2007 that still exists today. They operate under a bare below the elbows policy, primarily from an infection risk. The AMA in 2009 actually took a vote on whether they should ban the white coat for the profession. They ultimately decided not to. And even professional infectious disease societies have published guidance stating maybe we should really rethink the white coat and its use in clinical practice today. Where do each of our hospitals stand? At Denver Health, the policy says that uniforms must be worn as required by the department and/or division. So leaving it up to kind of each person in their division to decide. At the VA, they have a similar policy, but interestingly, they note that white lab coats must be laundered regularly, ideally daily. And UC Health, the policy is that staff providing direct patient care are required to wear clinical uniforms, scrubs, and/or lab coats. For our medical students, the School of Medicine has a policy that states students caring for patients in non-routine or emergent situations, trying to take out the emergency room and clinic, so basically when they're in the hospital, should wear white coats or other protective attire. The internal medicine residency program does not have a specific white coat policy, but we do fall under the overarching graduate medical education policy, which states that we should exhibit a professional appearance in the clinical work environment and abide by each of the hospitals that we're currently rotating at. So the bottom line from the history of the white coat is that it's been present for more than a century, with an evolving role that has sparked debate. And today there remains no universal policy regarding its use. Let's talk about the current trends then in wearing the white coat and where we stand right now. We'll first take a look at the national data. This comes from a Doximity poll that was done in 2023 with 4,000 physicians, and they asked, what do you prefer to wear in your clinical practice? I'll show you the top 5. Pathology comes in at number 1 with 79%. I think makes sense. Neurosurgery at 75%. Cardiology and infectious disease are tied at 70%, which I think is interesting with this large concern over infection. Infectious disease really coming strong. And then thoracic surgery at 68%. How about the bottom 5 that do not wear a white coat? The one that is least likely to wear the white coat is pediatrics, followed by PM&R, emergency medicine, orthopedics, and neurology. General internal medicine falls right in the middle at about 62% of practitioners wanting to wear the white coat. The most interesting piece of this study is that it does change by age. So those that are 30 to 39 are less likely to prefer to wear the white coat compared with those that are 70 and older. Let's take a look at what we do here locally. To help answer this question, Allie and I sent a survey, thank you for those that are in this room that filled it out, to the various divisions within the Department of Medicine, both at University, the VA, and Denver Health. We had a total of 214 responses. A majority of the responses came from attendings, with an even distribution of attending years, speaking a little bit to the age component that we'd found from the national data, but a trend maybe towards more junior, 0 to 10 years. And that hospital medicine was the most represented, followed by infectious disease, primary care, and other, including GI, renal, addiction medicine, palliative care, geriatrics, hem-onc, and pulm crit. So the number 1 attire that was most commonly worn here at the University of Colorado is scrubs with a fleece or soft shell jacket, AKA the Patagonia. And I see a few people in the room wearing this attire. The number 2 most common attire is business casual. And at number 3 is where the white coat enters, with business casual and a white coat, followed by scrubs alone, scrubs with a white coat, and then a mix of other, which is just permutations on all of these kind of other ideas. We had a write-in section, and the most common write-in response was just the addition of a tie. When you break this down into attendings and trainees, attendings are more likely to wear business casual, kind of an even split if they add the white coat to it. But trainees significantly are most likely to wear scrubs and a Patagonia. This also breaks down among gender. So females are more likely to wear a white coat than males. I'll then be in the caveat, there were no transgender or gender non-binary participants in our study. And then non-white attendings more commonly reported wearing the white coat than white attendings. So from this, we've learned three major things. The first is that the most common attire is scrubs with a fleece soft shell jacket, the Patagonia. That trainees most commonly wear scrubs without a white coat, and that gender and racial preferences for the white coat may exist. So we'll spend the rest of our time today really talking about the pros and cons of the white coat and its use today in modern clinical practice. To help answer this question and to help frame our conversation, in our survey, we did also ask participants why you do or do not wear the white coat. We can see that when asked, why do you wear the white coat? The top three things that were cited were role recognition at 43%, pockets at 26%. I will not be talking about pockets because I don't have any data on that. To symbolize expertise at 11%. When asked, why don't you wear a white coat? Similar to the things that you had mentioned in the poll, personal comfort, the dominant culture of the institution, and concerns over infection risk. So to frame the conversation, we've developed this schema about all the things that predominantly affect why we do or do not wear a white coat today in current clinical practice. I do want to make one quick note on professionalism, and I really want to be clear that we are untying the white coat from the concept of professionalism. The white coat is simply a piece of clothing that you may choose or choose not to wear. It has no bearing on how professional you are or may seem in your current clinical practice. Professionalism is a set of values that you hold. It is not at all related to whether or not you wear the white coat or don't. Okay, we will start talking about patient preference. Interspersed throughout, I've included a few quotes from our survey to help frame exactly what people were feeling that helped us decide what we were going to talk about. For patient preference, someone said, I felt that they, the white coat, took away or put up a wall between me and my patients when it came to subtle interactions. I believe this, the white coat, makes me appear more professional, knowledgeable, and reliable to patients. I stopped wearing a white coat my first year of residency, and I feel like patients don't have a preference for it anymore. So what's the data? Thankfully, our very own Dr. Chopra has studied this quite extensively. This study comes from 2018. And what Dr. Chopra and his colleagues did is they did a questionnaire-based study that they sent to 4,000 patients across the United States, 10 academic medical centers, mix of inpatient and outpatient settings, but non-surgical. Of note, 71% of the respondents were white and 36% were 65 years and older. And in the survey, they gave them the following photographs. And they asked them to rate the physician on a Likert scale from 1 to 10 in the following domains. How knowledgeable is this physician? How trustworthy? How caring? How comfortable do they make you feel? And how approachable are they? And what they found is that the white coat with business casual had the highest average patient composite rating from that Likert survey. And that was actually statistically significant compared to all of the other attires that were pictured in the survey. The lowest response you can see came from the casual attire. But speaking to the second lowest is actually the formal suit that I think is at some medical institutions, has the lowest, second to lowest patient preference. Other interesting findings from this study include that 53% of the patients said a doctor's dress is important to them, and 36% of patients said a physician attire influenced directly how happy they were with the care they received. Another similar study was done in 2021. This time was a similar patient questionnaire, but single center Johns Hopkins, 487 patients, average age of 36.2, 76% white. And again, they sent them photos of models in varying attire and asked them specifically about what their perceived experience is of that physician in the photo. They found that the white coat with business innerwear had the highest amount of perceived experience, and that was statistically different than the fleece or soft shell Patagonia when worn with business attire. They found that scrubs, when worn with a white coat, had a higher perceived experience than scrubs worn with a Patagonia. And then even taken together, the white coat with business attire was statistically more likely to have a higher perceived experience than the white coat with scrubs. But what I had continually heard during all of medical school was that the white coat just makes patients not want to talk to you. And that's why we shouldn't wear it. And that's the reason I didn't wear it through all of medical school and all of residency. But thankfully, they've also studied this too. When given a very similar study setup, they asked, which of these physicians are you most likely to discuss intimate social and sexual problems with? And 71% of the patients said they wanted to talk to the professional, which was the business casual attire with a white coat. So from a patient side, it appears that the white coat positively impacts patients' perception of their physician as someone who's trustworthy, caring, experienced, among other traits. So for patient preference, there is an increase for patient preference, as seen in the literature that's conducted very recently. Let's talk about role clarity, which was the #1 reason that people said that they chose to wear a white coat. Someone in our survey said, I suspect wearing the long white coat with my embroidered name and credentials would reduce the microaggression that I experience nearly daily on the wards and units. As a short brown female physician, I've noticed a distinct improvement in role recognition for myself while wearing the white coat. As a young female attending, I wear my white coat almost all the time. I think it helps patients and staff identify my role on the team, especially because I look young and patients are likely to defer to the male residents or students on the team. I've had deep conversations about end-of-life care or procedures, and the patient says, don't worry, honey, the doctor's coming. We know that the white coat does increase role recognition as a physician. From the same study about perceived experience, with the photos that they gave and the models in the different attire, they said, what is this model's role within the healthcare team? And when the model was wearing a white coat, they were most often identified as doctors for the male and female. However, interestingly, females still less likely to be identified as a doctor compared to the male counterparts in that study. When wearing scrubs, males and females are most commonly identified as surgeons. Again, females still less likely than males. And when wearing casual attire with a Patagonia, we have identification as a medical technician or physician assistant most commonly. So it seems that wearing the white coat does increase the ability to be recognized as a physician from this study. But we know that it's not just patients that are misidentifying our female colleagues. Another study asked who this role misidentification comes from, and it comes from not only patients and families, but nurses, support staff, other residents, and attending physicians. We'll first talk about the importance of proper role identification from the patient side. Again, we know that patients are very confused about who is their doctor. In a study out of the University of Chicago, 75% of patients inpatient could not name one physician on their healthcare team. And of those that were able to name one physician on their healthcare team, 60% of them were wrong. And while we don't have any concrete data yet saying if you wear a white coat, your patient will have this better outcome, we can theorize at how that might play out. So what I personally might theorize is that if someone is wearing their white coat and the patient knows that they are their physician, they're more likely to be participatory in their medical care, to engage in discussions about their health outcomes, the medicines they're taking, their plan for the day. And we do know that when patients are more participatory in their care, they have less adverse events and a higher perceived quality of their care. But again, I do want to be clear that there's never any study that's done on a direct correlation between the white coat and what the patient health outcome might be. Now let's look at the provider perspective. And this literature is quite vast. A great study was done and published in Academic Medicine in 2021 on mistaken identity, where they surveyed IM, surgery, and emergency medicine residents at a single center and said, how often are you misidentified as something other than a physician? 100% of the women respondents reported being misidentified at least once, compared to 49% of men. And 35% of women were misidentified more than 8 times per month, compared with just 1% of men. And this has real implications, is that women are more likely to feel that their decisions are more often questioned by patients, questioned by nursing, and that it negatively impacts their relationship with the patient family and they're less satisfied with their job. We know from a lot of literature that this sex-based role misidentification is associated with lower levels of well-being, increased emotional exhaustion, and an increased depersonalization of that individual, and that these microaggressions and stereotype threat negatively affect the learning experience and performance of our trainees. And again, I want to highlight that there's not yet been a study looking at other racially minoritized individuals, but we can imagine the effects are very similar. So the bottom line on role identification is that the white coat increases correct role identification, and this is associated with increased patient participation, with a possible improvement in patient outcomes, but most importantly, that provider role identification is associated with decreased burnout and emotional exhaustion for marginalized identities. So from the standpoint of the white coat and increasing role clarity, it may help. Now we'll talk about the infection risk, which is very nerve-wracking when there's infectious disease colleagues here. Okay. Someone in our survey said, I wore one before COVID, but I switched to scrubs with a jacket to avoid dry cleaning and reduce infection. Someone said, I wear it less and less as time goes on due to this infection risk. So there's also a lot of literature that the white coat does harbor infectious pathogens. We know it does. We've cultured the white coat. We know that it has MDROs, it has MRSA on it, has Pseudomonas on it. It's got a bunch of gnarly stuff. But the question is, does this actually differ from the other clothes that we wear? Again, we have two experts here on campus who did that study, Dr. Marisha Burden and Dr. Rick Albert at Denver Health in 2011, where they randomized people to either wear a white coat or wear a newly laundered uniform each day that was fresh and they got every day versus their standard normal white coat. At discrete time points, they took cultures from varying comparable sites on the uniforms and saw how many bacteria grew. And they found that there was no difference in the bacterial colony count on a majority of the comparable sites on the uniform versus the white coat at 8 hours, kind of the end of the workday. So this newly laundered uniform may not be as good as it seems. What other attire do we know harbors bacteria? Ties have an increased bacteria compared to a regular shirt. Our stethoscope has verified patient skin to stethoscope transmission. And I don't know about you all, I don't typically wash off my stethoscope between every patient, but really maybe I should because I'm touching that right on there. Okay. So great question, what about laundering? Why should we just launder it daily like the VA suggests? This is my favorite part of this study because what they did is on the newly laundered uniform, they tracked the rate at which the bacteria accumulate. And by just 3 hours, nearly 50% of the bacteria was present on that newly laundered uniform that was present at 8 hours. So Dr. Burden argues that you would have to wash your white coat so frequently to get it truly without any bacteria that it's impractical to do that for daily use. What about antimicrobial scrubs? I didn't know that this was a thing until doing this literature, but hot topic. Great, 2 trials that looked at this. Again, Dr. Burden. No difference with the antimicrobial scrubs versus regular scrubs. And we still to this day do not have any literature that shows that a white coat bacteria has been passed on to a patient and led to a healthcare associated infection. So again, we know that white coats harbor these infectious pathogens, but all clothing does in our patient care setting. And we need more studies to evaluate if this is transmitted to patients and linked to an actual clinical infection. My question for you, especially for the trainees, how often do you wash your Patagonia? I was really hoping daily would win out. Not the case. Weekly, it's not bad. Every month, maybe not as good. And I don't know, 16% wash it? I don't know. Okay. Interesting. Something to think about. Again, we don't have literature on the Patagonia's infections, but I have a theory. Okay. All right. So from an infection risk standpoint, I can't totally say that it's no infection risk because we do know that bacteria are there, but I can't say for certain that it actually links to an adverse event for a patient. Let's talk about the predominant culture of the institution, which is one of the most cited reasons why people don't wear a white coat here at the University of Colorado. Someone said the culture here at CU is less frequent white coat usage, which definitely makes me feel a little bit out of place. I used to wear one regularly at prior jobs. Local culture is the biggest factor for me. So are there differences in the white coat use at varying clinical sites? From a geographic difference standpoint, a survey was sent out to surgeons in the United States and asked what their preference is about whether they wear the white coat or not. They found that those in the West and Midwest were most likely to wear their white coat in the hospital. There were no geographic differences for clinic attire. And I think most importantly, there was no difference by the hospital type, academic, community, or an academic community hybrid. What about patient preferences? Again, Dr. Chopra did this study. So when sent that same patient questionnaire to a bunch of places around the world, including US, Japan, Switzerland, and Italy, what they found was that the white coat with business casual attire was the predominant patient preference in the USA and Japan. But interestingly, white coat with scrubs was preferred most predominantly in Italy and Switzerland. From the perceived experience study I talked about earlier, they found that folks had decreased patient scores for all the geographic regions except for the West for the scrub in Patagonia. So maybe the trainees are not wrong that the scrubs in Patagonia could work here. And I want to talk just a little bit about medical specialties. Does this differ outside of our internal medicine family? In studies about patient preference, we asked, does the setting at which the person is practicing influence this? They said yes, that they prefer a white coat with business casual for their primary care hospital physician, but they prefer scrubs for their emergency medicine and surgery physicians. And interestingly, they prefer scrubs more often alone than with a white coat. So from a culture standpoint, the bottom line is that patient preference for the white coat varies across diverse geographic regions, practice settings, and medical specialties. So from culture, it maybe just depends on where you're practicing. And then we'll take a look at the team dynamics and how this impacts the decision to wear or not wear a white coat. Someone said, because my learners do not wear a white coat, I struggle with how this exacerbates the power differential between me and the rest of the team. When I first started attending, I thought it maybe looked stuffy to wear a white coat with learners, and I worried more about the perception from my learners. This is exactly what I felt when I was going to be putting the white coat on for the first time. And I really wondered if the white coat in particular would decrease the psychological safety that I was trying to create with my team. And while we don't have any specific literature looking at the white coat and its impacts on psychological safety, we have a ton of literature looking at how to create a psychologically safe learning environment. And a lot of that work has been done here by Dr. Tyra Fainstead. And in particular, we know we can create a psychologically safe learning environment by having clear expectations, promoting self-efficacy, promoting team engagement and autonomy, and providing frequent feedback. Though we can destroy a psychologically safe learning environment by showing disinterest in our learners, dismissal of their questions, not giving them autonomy, and providing unclear expectations. And the only way to restore this environment is to acknowledge and apologize for the team member misbehavior. At no point in any of the studies we reviewed or in the focus groups that Dr. Fainstead did was the white coat ever mentioned. And so what I might argue is that if you're really worried about the impact of the white coat on psychological safety, we have evidence-based things that can increase psychological safety that you can continue to use even while wearing the white coat. I do want to bring it back, though, to the comment that was made as a chief resident to Allie about the concern about how wearing the white coat would be for her as a woman of color with her medical team. Someone said, I stopped wearing one for a long time, but I've recently purchased one and plan to begin wearing again. This is driven predominantly by my desire to be an ally for female colleagues who are compelled to wear one for role recognition. Someone said, I've been literally laughed at by colleagues for wearing it, but I don't think men realize what a privilege it is to not have to wear it. And so it begs the question if the white coat can be seen as allyship. That if we start wearing our white coats that are frequently normalized as someone who's a physician, do we make it more comfortable for other people to do the same? Is this a way to stand up for our colleagues that are not frequently identified? Something to think about, and something that I clearly did not think about before really embarking on this chief resident year. But I'd be curious from those in the room, have you ever explicitly talked with your team about wearing a white coat? And specifically, should you all do that as a team or as a group? No, 87% of feel predominant. But interestingly, some people, yes, do this, which is a little bit exciting because it's not something that I had ever really encountered in training. So something to think about for sure. So the bottom line from your team dynamics is that it may be worthwhile to discuss wearing a white coat with your team. And then if you're worried about the impacts of psychological safety, that there are evidence-based ways to increase the psychological safety of your team. So looking here at our final schema, we know that the white coat increases patient preference, increases role clarity, plus or minus on the infection risk. And then for culture and team dynamics, it just depends on you and your personal practice and maybe where you're practicing. But I do want to be really, really clear in what Ali and I are saying. Are we saying that if you wear the white coat, patients will trust you more, you'll decrease the micro and macroaggressions that you experience, that infections will increase, but you may have better medical team dynamics? Maybe, but that the white coat is just a tool, that it can't totally make or break your clinical practice. And that if you want to not wear a white coat, you can still have the same level of patient trust, that you can still be recognized as a physician, and that the roles, that the white coat is not meant to dismantle the systemic oppression that has existed for the medical profession and to change the culture that the predominant group has had. It's just a tool. But like many grand rounds, this has brought up way more questions for me than I have answers for. I'm wondering, is there still a direct transmission of the white coat bacteria to patients? Unclear. Is there similar improved role recognition for racial minorities with the white coat usage that has not been studied, but would be a great study to do? Does wearing a white coat directly lead to improved health outcomes? And then the one thing we didn't touch upon today, because there's not a lot of literature on it, but what is the impact of the white coat on the multidisciplinary team? Does it make nurses not want to talk to you as frequently? Does it impact other interactions that you have? That again is not studied and is a little bit unclear. But I bring it back to what we had when I put on the white coat, that I did feel a sense of pride putting it on. And I do wonder for us as a profession, where we go from here in this large era of medical misinformation and trust. What does the white coat mean currently in clinical practice today? And ultimately, it's an individual decision. So what are you going to do with it? My main 3 takeaways. The practice of wearing the white coat has evolved significantly over the past century. Wearing the white coat increases role identification and may lead to decreased burnout and improved job satisfaction for folks. And that it may be worthwhile to talk to your teams about wearing the white coat or not. I have to end the conversation with gratitude for all of these incredible people up here that we met with and talked about some of these concepts and ideas and were instrumental in getting us to where we are today. And then most importantly, I have to thank the CU residents, who are the entire reason that Ali and I get up and do what we do every day. We appreciate their dedication to patient care, their vulnerability, and their desire to move our profession forward. And so I thank them so much for all the work that they have done. And with that, I will close and take any of your questions, but also encourage any thoughts or conversation that we can have. Thank you.
Nick, that was a great talk, and Allie, we should recognize her for her contributions as well. I'm sure the audience will have questions or comments. In fact, I see MFA lining one up right there, so go ahead.
Great. Thanks so much, Dr. Bianchina, for your wonderful grand rounds. This question is from Dr. Sonia Flores. When you look at the top reason why female and minoritized physicians wear white coats more frequently, did you find whether there is a gender and/or ethnic bias that indicates that role recognition is necessary to get the respect gender and ethnic minorities may not be receiving from patients and/or other providers? Has this decreased the misidentification of these providers?
Yeah, that's a great question. Yes, it definitely decreases the misidentification. And we have studies that show that when someone is wearing a white coat, they're more likely to be recognized as a physician. But as you saw from those graphs, there's still a difference that even when wearing the white coat, males and females were different in terms of how they were recognized. So obviously there's just so many systemic factors and biases that impact that. And so I think a lot of future work is needed to be done to find that out specifically. And I think ultimately to bring it back that we can't, the white coat can't totally get rid of all of the systemic biases that people have.
Terrific. I'll ask one. We got one in the back if they want to get it. Where I went to medical school, all students got a short white coat.
Mhm.
And I think that me graduating medical school wasn't that I was excited about going on to my next step, but I got a long coat. And that was a really big thing.
Yeah.
Is there any data in students in terms of having a short coat versus a long coat and how that sets up a different differential within the team?
Yeah, there's not any data on it. I definitely think that the shorter white coat does differentiate the students. And we heard in talking to some folks that was helpful because they knew who the student was or who the student wasn't. I do worry a little bit about the psychological effects that has, because I do think it symbolizes in a way that you're not as good as, or you're not yet this person. And I worry about that with the white coat. But again, there's not specific kind of data on it. And even when I became a resident here, I actually wasn't terribly excited to get a long white coat. It didn't have as much of a weight for me as it did, maybe because I didn't wear it as often in med school.
In the back.
That was very interesting to hear. And can you just maybe say a little bit more about the psychological safety of wearing the white coats? Because for me and others personally, I feel psychologically unsafe sometimes if I don't have it on. And then if I forget my ID in the car, forget about it. I'm in a panic. And then the second part of that is I noticed that a lot of the IDs now, it says doctor in big letters, and that helps as well. Has there been data looking at white coat plus minus big doctor on the ID?
Yeah, I think that's a great point. I especially like I think the data to support that when some people are wearing the white coat, that you just feel more safe. And I think that just has such large implications. And I think especially for our trainees that are in such a power differential that they don't always feel like they can speak up, or that when they're misidentified that no one is around to help them. And so I have big concerns about that for our medical trainees in particular, and want to encourage them more often to wear the white coat. And then regarding kind of the name identification, like the badge buddies, the study that I pulled about who was misidentifying the physicians was from a study that looked specifically at does the badge buddy help, and it does. And then I even found an interesting study that someone in the surgery field did where they actually put names and roles on surgical caps, and that helped as well know who in the room was doing what when you don't have easily identifiable badge or things like that. So for our procedure specialties is also something to think about too.
Yeah, and again, congratulations on a great talk. So patient preference is largely measured, as best I can tell, by a judgment about a generic person, right? So it's somebody you don't know, they're dressed this way, how is your preference? Did you come across anything, and I imagine that's more important in a hospital setting, or, where first impression is so much more of a big factor in the relationship. Did you find anything about longitudinal relationships and how that impacts that? And as somebody who hasn't worn a lab coat, and none of my patients have seen me in clinic with a lab coat, I imagine it would be a topic of conversation if I were to wear one.
Yeah, yeah. No studies looked at that longitudinal relationship. And I think I keep coming back to the way that I frame it in my mind is that the white coat will increase these patient factors if you are the first person walking in and never having said anything. That it like buys you a little bit of something, which I agree is maybe more important for the quick interactions, the inpatient side. But I do think that the white coat by itself cannot make a patient suddenly like you if you don't have that therapeutic alliance. And there's so many ways to create that therapeutic alliance without the white coat that I think that suddenly to say, if you suddenly bring it in, that it's going to make things so much better is not true.
Nick, great talk. Reflecting on matters of patient preference, I think there's maybe two layers to that. There's the if there's a patient preference, and then there's the why. And thinking about those two layers, I guess we could imagine there are some topics where when we're met with a clear patient preference and a rationale for that, sometimes we may be champions of that and try to uphold that. And for other matters, we may, as the medical community, actually try to change that thought process in our culture and in our society. So my question for white coat is, did you find any reasons as to why patients might prefer the white coat? And if it's something that we as a community should seek to uphold, or is it something that we should allow to evolve and potentially change?
Yeah, it's a great question. The tension of those two things is where I probably most struggle with my decision to wear or not wear a white coat, because on the one hand, I think that patients come from it from the setting of, that is who I see and is frequently put on the TV as someone that's a doctor. And I think in some ways, because we're not as predominantly wearing the white coat, I imagine that is evolving. And there's some interesting data, both from Dr. Chopra's studies, but replicated in many others, that there actually is an age-related preference via patients as well. And so I wonder if as patients age, that is going to kind of go away a little bit. And then I also do think that if I wear the white coat, am I reinforcing the patriarchal white image of the physician? And am I not letting some of my female colleagues or those from other backgrounds be seen as such? Because again, I don't want anyone to feel that they have to wear a certain piece of clothing to get the respect that they deserve. So I struggle a lot in that tension.
Nancy.
Is it on? Thank you for the talk. Very interesting. I wanted to just comment about bacteria on white coats or other clothing. There are only a couple of known infections that humans can acquire from fomites. So we tend to think of clothing as inanimate objects. One of the instances would be RSV can be transmitted, but it's not, it gets on your clothes and then you get it. It's you probably touch your clothes and then wipe your nose. Okay. But if people are worried that there's bacteria on their clothing, I'd like to remind you that microwaves kill bacteria. So you can microwave your Patagonia jacket if you like. Okay? They also do not like to be frozen. So you could store your Patagonia in your freezer overnight and you'll be good to go the next day.
That'd be amazing.
Practical tips from Dr. Bannister. Thank you. Any other questions? One more.
That was a great talk. Thanks, Nick. I'm curious as to how contact precautions sort of factor into these questions, just because half of the patients that we see on ID are, in contact isolation, and we have to wear a gown over what we're wearing anyways. So I just was curious on your thoughts on that.
Yeah, there has not been any studies looking at if you suddenly decrease that when wearing that precaution. My personal practice is that I just take off my white coat if I'm ever going into that room because it's more comfortable to not have a bunch of layers on. And I also think maybe this will decrease that transmission a little bit, but they haven't directly looked at it. And interestingly, I couldn't find a lot of great studies done like during the pandemic about this specifically, because I thought this is the ripe area where we'll find all this literature, and there wasn't a whole lot being studied. So still, it's a food for thought. I do think that since some of these studies have been published, so I imagine our infection control practices have gone up and a lot more contact precaution wearing. And so that might also impact some of the data in the current landscape.
Dr. Bianchina, what a great talk. Thank you so much for a great
Thank you all.
medical grand rounds.